Yeah, but by the time he's coming in, sir, you were mentioning a point about the cath lab activation.
No, no, I was just joking. I said since it's taking time, lesson.
Yes, sir.
Actually, recently we saw one peculiar case. A very young lady, she came with 3 days onset of substantial chest pain, 20-year-old girl. She came with severe refractional pain, SOB, and she consulted a local doctor. So then they said nothing, only acidity. They gave medications. And third day, she uh, went to nearby hospital, very hypertensive, unrecordable blood pressure. Then they shifted to our hospital. That time when we saw admitted, we suspected it's a COVID, like a myocarditis. Then we took CT chest didn't show much. So immediately that PCR test was not done. Then we admitted in COVID ward. Next day morning, ECG showed classic left main occlusion, like a ST elevation in AVR, AST elevation V1 to V6. And then we thought, though the COVID test was pending, we took her immediately to cath lab. We did the angiogram. Angio was perfectly normal. This type 2 type of infection, it was reported even in Mount Sinai also. So they reported 3-4 cases, like a type 2 MIs, STT elevation, elevation with mild T wave changes. It can mislead like a type 1 infection. So many times we have to be very careful, but we gave her IABP support. We were unable to put the ECMO because the femoral artery is so small. It's because the intense died, very unfortunate story. But we took the COVID test, both tests were negative. We took tracheal aspirate as well as the even pharyngeal aspirate, but both tests were negative. But in this, mostly I think 5 days later, if you are repeating the test, maybe could have been positive. But this type of unusual presentation we saw, even regarding aggressive management, now the recent webinar from the Mount Sinai, they were saying any acute MI, no need to, the mortality is very high. Better to go with primary PCI rather than the thrombolytic therapy. So initially, all countries, they are saying whenever COVID you suspect, go with immediate thrombolytic therapy. Wait for only threatening is there, that only go for primary PCA. But now the people are, guidelines are changing, treat it like a primary PCA, go with aggressive intervention, go with protective PPE, and keep him in isolation ward. If negative, we shift him to the regular ICU ward and treat. But all cases in emergency should be managed with PPE with proper protection. The chance of exposure is getting infection is very low when you keep a proper PPE and proper precautions if you take. I think that is my opinion.
So very well mentioned,
I request you to share.
Yeah, if we can go ahead.
Before we start, I just wanted to make a comment on what Dr. Kasturi said. Actually, it's a very important issue, Dr. Kasturi, that patients at times could be having type 2 myocardial infarction. And in fact, there is a paper by Sripal, Bangalore also, which shows that in the New England Journal of Medicine, they had 18 patients, all presenting with ST elevation. And 10 of their patients had actually normal coronaries, the kind of patient you saw. People feel that this could be happening because of the myocarditis, whether it is happening because of the Takatsubos, or whether it is a response to the acute interleukin liberation, the cytokine storm that we have. So it could be a consequence of all. And initial part, when the COVID happened, the ACC guidelines also mentioned that we should be hesitant to take these people to the cath lab. But now, ever since we have realized the kind of patient you had, and many people have seen this kind of type 2 infarctions, people feel that if you thrombolize these patients, it would be detrimental. So it is useful to take these patients to the lab to know what you are dealing with, and then manage. So type 1 and type 2 myocardial infarctions Both are happening actually in COVID times, and that adds to a much bigger challenge actually for all of us to manage. And as you said, first COVID can be negative. It has a sensitivity of 67% only, the RT-PCR has. So almost 33% genuinely well taken swabs, they could still be negative. It is very specific, but its sensitivity is low. So that's why it said that as you did second sample, maybe very early, if you do also, sometimes the swabs can be negative. So you need to repeat it after 48 hours or so.
Yeah. Yeah, very right, very
Yeah,
nicely
rightly
and very rightly commented, sir. We are also aware of the patient that we had just 3 days back who presented with a Levine sign to the emergency from a nearby area and came out to be a suspect positive, and yesterday he was declared to be positive. So I think we at that time got a COVID and waited before we could intervene, though he was in pain and then later on he stabilized. And I think there can be divided views. We were very happy doing that. It was done after discussing with Dr. Wander sir only, because having a COVID positive and taking to cath lab can have its own implications, especially in the kind of cath lab setup and negative pressures it needs, and the number of people who might be exposed to the risk. So, if may I request Dr. Wander sir to that we can proceed with the talk by the time Dr. Keshav Murthy is kind of able to connect. So, who does not know Dr. G.S. Wander? Dr. G.S. Wander is Chief Cardiologist and Professor in Cardiology at Hero DMC Heart Institute. He has been very actively and very ably managing the COVID crisis in this part of the country, and especially in the Anand Medical College. I would now request Dr. Wander sir to please present his talk on COVID and cardiology practice in the COVID era. What is the way forward? What are we looking to?
Well, thank you, Shiba. It's an honor to speak in this Hyderabad live, and thanks to Sarath. Smith gave a lovely talk, and Dr. Kasturi just shared a lovely case. So I'll just take you through actually as to how our practices as cardiologists are changing and what is the way forward. Actually, these are challenging times for everybody, but more so for cardiologists, because as Smith so beautifully showed us, that a lot of these patients have actually myocarditis, and these patients then turn bad. Actually, there is a right-sided heart failure also, because the ARDS situation that you have, that puts a lot of pressure on the right side of the heart, and they can have an acute cor pulmonale kind of situation. Then Smith also showed us there is a hypercoagulable state in this condition. These patients have excessive thrombotic tendencies. So there are more than one ways by which actually this infectious disease is affecting us. It might seem that we have lived for this new normal way of life for a long time. But if you really recollect, it was only towards while we were celebrating the New Year on 31st of December only, China reported for the first time to the WHO that such cases are being seen. Although now by satellite, the Harvard has seen that there were cases coming actually to China, and possibly people feel that there was some sort of a misreporting or lack of reporting, which could have augmented the spread of this particular disease. By 3rd June, we started seeing cases in Thailand and US. And on 30th of June, by the end of 1 month, WHO actually declared it as a global health emergency. And you all know by 11th of March, it was a global pandemic. And this was a pandemic which we saw after 10 years. The H1N1 pandemic occurred in 2009. And we all know the Spanish flu, which killed about 5 crore people, happened in 1919 or so, towards the end of the First World War. So we are virtually seeing a much bigger kind of a pandemic this time. And we all thought India is escaping this pandemic, and there were many theories going on, whether it's the BCG or whether it's our high immunity or resistance, but whether it's the temperature. But what we are seeing last couple of days is actually the disease has now come and rested in India itself. And we have reached the 4th stage in terms of number of cases in the world, about 3.5 lakh cases and about 10,000 fatalities. So we truly are going through a difficult period when this disease has now, we are another epicenter. Some of our cities have become epicenters of this disease. And India being a very wide country, the the policies that you will adopt in different parts of the country will obviously be very different. I was talking to a cardiologist in Delhi. They have given 100 out of 250 beds of a cardiac hospital. They have actually, Shiba Vibud I was talking to yesterday, he says 100 of their beds they have given to COVID. So they will, for a while, they will run both these services, the COVID treatment as well as the cardiac treatment simultaneously. But they are seeing many more patients than what we are seeing. Gangaram itself is treating close to 300 patients of COVID. So Delhi is having a different kind of a scenario than what Smith might be having in his city and what we are having. We have somehow less cases, but it can always pick up at any time, and we have to be. Sorry?
Okay.
Yeah, someone needs to mute actually. So we do know the fatalities actually, since Europeans have a much aging population, and we know this disease Smith showed us affects elderly people, our mortalities are less. And in fact, we have data from China which shows that the fatalities in less than 45, 50 years are much less. And as we age and we pick up some of these comorbidities which are related to the aging process, the fatalities go up, which was very beautifully explained by Smith. We in India had a lockdown pretty early. We followed it fairly well, but now somehow we seem to have got bored with it, and now that is what is showing the consequences of this increased infection. Certainly there's no harm in having a positive attitude, because this disease is all about attitudes and how we take up this particular disease. I was reading a beautiful editorial in one of the New England Journal of Medicine. Last week it has come. And what it says is that it's the people who are most important in the COVID era rather than the other things, and it's the people in the frontline care delivery systems. Actually, these are the people who have to be taken into line, because they are the ones who are managing these patients, rather than sitting in offices and creating some guidelines. The individuals who are actually managing these patients and dealing with them, they have to be on board for forming guidelines, for forming protocols for your own hospital, because they are dealing with the problems. Of course, we need space adjustments in our hospitals, because the same area has to be now divided into different, the staffs have to be divided, a lot new supplies of PPEs, masks and all have to come. And of course, systems have to be developed in our, so these systems have to be developed in our hospitals where we have a teamwork, because these are demanding times, and in the demanding times, actually the sharing of responsibilities have to, there's something wrong actually, the slide. Can we restart? Okay, fine. Yeah. So this is actually what I wrote in one of the local newspapers a couple of days back, actually, that we have to realize there is a lot, as Smith said, there are a lot of things which we actually don't know as yet. And as the disease is evolving, we are realizing actually what we know and what we don't know. And we have to keep changing our protocols according to our knowledge into what we learn regarding this disease. And the more we prepare ourselves for handling this problem, the better it will be. But still, we have to keep in mind that there will be errors in our protocols. As Shiba was saying, we have developed in our hospital a protocol that our patients are admitted in the emergency. We get their COVID tests, fully realizing that COVID tests can be false negative. But once we have COVID, temperature regulation, some of the non-COVID markers like lymphopenia, increased ferritin levels, high D-dimer levels, we have a look at chest x-rays, we have a look at the totality, and then these patients get shifted up to our first and second floors in the wards. So by this means, we have actually doctors and paramedics in the emergency area, which we have called as a suspect COVID area, where they are all wearing level 3 PPEs. So we are now quarantining much less of our healthcare workers than what happened in the initial part of our experience when these patients were coming. So we are depending heavily on these, on the RT-PCR, which luckily is available in our own hospital. And now actually the antibody tests are also going to be available in a couple of days. We have altered our hospital in a very massive manner. This is actually the flu corner. We are actually a 200 bedded facility, which is part of a 1700 main medical college building. So this is what looks like for the main hospital, where the staff actually get separated and the flu corner records individuals, their histories are taken, and then they are subsequently shifted to the flu corner in the cardiac center, where itself level 2 PPIs are worn by our staff there. And once a triaging has happened, it is only after that these patients, a large part of our consultations are also actually being done on phone. In the initial part when COVID came, we were contacting our patients by helplines. Now we have developed system in our hospital and we are attending to our patients, because we are still in a phase where the disease has not, we are not a containment kind of area in Ludhiana at least. And out of every 100 tests, about 3 to 4 COVIDs would come positive. So we are still in a low positivity area. But as Smith said, we are telling people actually who are coming to our hospitals, those more than 60, 65 should not come to the hospital as attendants. We also know men are afflicted 2 times more frequently than women by this disease. The smokers, the fatty individuals, patients who have diabetes, those who have cardiac disease, that is, so people need to know who are the high risk individuals. So attendants should primarily be actually youngsters, and elderly people should avoid coming to the hospital. Some elderlies are being advised to have teleconsultations. One of our surgeon is doing 10 to 12 teleconsultations in our hospital. Of course, our attendance has now changed because we do not want to depend upon the same finger marking. That would be a mode of spread of infection. All patients coming are advised to get the Arogya Setu app downloaded, so that we contribute towards the national movement. Air conditionings have been, we do not have actually negative pressure air conditioning in the cath lab or in the OTs, but we have segregated parts. We have separate AHUs now. Some new AHUs have been installed, and AHUs in suspected COVID areas are separate, so that air does not get circulated to the rest of the hospital, and the air circulation times have been increased to 10, almost 12 times in an hour. So we are making whatever modifications are possible in our air conditioning system also. We have installed actually iPads by which patients actually are advised their attendants do not visit within the suspect COVID area, and they seek consultations from outside that area only. The level 3 PPs, as I said, for the indoor areas where suspect cases come, and level 1 to level 2 PPs for patients, for doctors. It's not only for us actually. This is a picture of actually a beauty parlor. So you see, everybody is going through what we are going through, and everybody has to wear PPs wherever the contact is close. Our patients give a consent before they come, because some legal issues can be there, and they are made to understand that they are coming to a hospital where they can catch up this disease. So that this consent is signed by all individuals who come to us. And of course, our protocols for the hospital, we have shifted to damp dusting, hydrogen peroxide fumigations are being done, and 3 times in a day, all floors with, so the 5 bucket model for cleaning of the hospital is being used. The 4th time it is cleaned is with the sodium hypochlorite solution, and then with the clean solution. The changes that we are making significant in our, which everybody else in the country is having actually. The luckily situation regarding the N95 masks, the PPEs availability, the panic is gone, and now the availability part is much better. So we are not actually having much issues with the availability of PPEs and masks. In fact, it is known now that all in public places should also wear cloth masks are good enough. So any patient entering our hospital gets a cloth mask before they can enter. All our admitted patients are wearing masks. We insist upon them at the time of our rounds that they wear the masks properly, because both the patient as well as the doctors have to be wearing masks for preventing spread of this particular virus, which is rather very contagious as compared to any other virus. As I said, the telemedicine has now come to our country. We have used this HealthPlix, which is a fairly popular kind of a teleconsult, but there are many teleconsult portals that are now prevalent in our country and people are using differently. A colleague of mine actually emphasized in another newspaper editorial, he said that we should be bothered about these other demics. What we should not just be centric to the COVID pandemic, but our commitment to treatment of patients of acute myocardial infarction. Strokes are higher. He's a neurologist. They are seeing many more large vessel strokes. And of course, we have the usual, number of infectious diseases. And towards the fall now, we are going to have the so-called tropical disease infections that would normally leptospira, other infections that come towards the time of fall. And that's the time when it is going to become more challenging for us, because dengue, leptospira, all these things will come up, and we will need to make a distinguish between these, who is suffering from COVID and who has other. Of course, government is now playing a lot of issues with private hospitals. Sometimes they are preventing us from doing COVID tests, but we strongly believe that unless you have these tests, healthcare personnel are a very, very important commodity in this whole fight against the COVID-19. We know the PCR test can remain positive for 3 to 4 weeks also, but the data that we have today is by the 7th or 10th day, these patients become non-infectious. So the CDC guidelines now are that if a patient has been asymptomatic for 3 days, or patient has been hospitalized for 10 days, you can safely discharge these patients, because even if the PCR is coming positive, they are no longer infectious to other individuals. Although they are still advised to self-quarantine themselves in their homes for a period of time. But as far as our hospital function is concerned, Shiba knows it. We have a common unit now. We all function as one. Doctors, nurses, dietitians, we try to carry as less of them towards the rounds, because the exposure has to be reduced. And one of us works in the cath lab, one person takes the rounds, 1 or 2 of us work in the OPD. So this segregation and teamwork amongst nurses, doctors, paramedics, the security men, it is all very important. Of course, we have guidelines now from the CSI. They have given as to how heart failure patients need to be treated. Smith beautifully told us how myocardial injury occurs and how these patients are to be treated. In fact, we have been noticing that none of these agents actually, whether it was lopinavir, ritonavir, which were anti-HIV drugs, which were initially thought to have potential, then HCQ, azithromycin combination people thought, then we know tocilizumab, which is an interleukin-6 antagonist, we have remdesivir, the convalescent plasma. None of these actually in any randomized trial no modality has been shown to be beneficial to these patients. What we for sure know now is be more aggressive, as Smith said, with anticoagulants. So we put them those with high D-dimers. We put them on low molecular weight heparins more aggressively. And secondly, delay their ventilation as much as possible. Thirdly, prone positioning is useful. And then, of course, general good care of these patients. I don't feel we have data with regards to any of these drugs. The CSI has given actually acute MI care. Initially, we thought it is thrombolysis is the way to go, because unless we have PCR available. But now it is realized, as we discussed shortly actually, that with proper PPs, large anterior infarct patients, young patients, you will need to actually take small infarcts, inferior infarcts, which are low risk. So you will need to segregate your patients into low risk and high risk individuals, and then determine what mode of reperfusion out of the two modalities you are going to use. If your patient has frank, multiple risk factors, patient has coronary artery disease, patient comes with a small infarct, you obviously will thrombolize these patients and not subject your, because level 3 PPs doing a procedure is actually quite an ask whenever you are doing this. A beautiful actually editorial I saw and you must have seen, actually most of you, in the European Heart Journal. People are now drawing lessons from the Bhagavad Gita, and the authors actually say that the healthcare personnel are the Arjuns here, who are actually having to fight. And they believe that it's not just the healthcare doctors, it is the nurses, the security staff, the receptionist staff. And the fighting, the Kurukshetra here is the hospital actually environment where we are going through this particular fight. But the enemy here are four actually for the doctors. Of course, COVID is an enemy, but the other enemy is the what they call as the infodemics, or the wrong information that is happening. The third enemy is protocols which are being forced upon people without knowing actually what is happening in the real life scenario, and also our lack of knowledge with regards to with this particular. So we are fighting these four enemies, and as Bhagavad Gita said, the dharma has to be we should, rather than using fear-based or emotion-based medicine, we should be pursuing actually evidence-based medicines in terms of what we already know. And our dharma is not to look at the consequences or the ultimate outcome of any particular effort, but it is the sincerity of the effort which is more important. And that is what is demanding and challenging, and what most healthcare personnel in our country are so ably doing. So I would end here actually by saying that we need to develop our own protocols. India is a very diverse country. Somewhere the disease is more, somewhere it is less. So there are areas where the disease is very little actually. I was today morning talking to a person from one district of Punjab, from Fazilka. They barely have any patients of COVID in that particular district. So their protocols will obviously be so local protocols are very, very important. We are all equal in this fight. Carry your healthcare personnel, your paramedics, and keep changing your protocols that you develop. Of course, these are demanding times, and we need to look after ourselves, our staff, and it's going to be a rather longish battle. We know we have learned a lot of lessons, but there are still many more. A vaccine, actually, I was listening to Dr. Fossey yesterday. He feels that by November or December, the Moderna vaccine company is already on phase 2 trial now. And in July, they will be starting the phase 3, in which they will be doing 30,000 subjects. And while they are doing an unprecedented thing they are doing, while the phase 3 will be going on, the production of the vaccine will go on. So if this trial comes to be positive, the vaccine will be there for distribution. If it comes negative, then it will be a wastage of the vaccine. So people are trying to fight this particular battle. We are going to win it, but we all need to be together in it. Thank you very much.
Thank you so much, sir. It was really an excellent and great oration with great insight into the disease over the months that we have proceeded. I've got a message from the organizers that we are falling short of the time. So we would take the next talk, and maybe after that, some words of discussion. So may I now request Dr. Keshav Murthy to please come up and give his talk on cath lab activation in COVID era, Indian scenario, when and how.